Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN project, and thank you for joining us today and our friends at Manic Community Health Center for hosting today's session, Abnormal Tests in Pediatric Endocrine Practice, When to Worry and When to Reassure, with Dr. Paul Kaplowitz. Dr. Kaplowitz is a professor emeritus of pediatrics at George Washington University School of Medicine and the Health Sciences and the Division of Endocrinology at Children's National Hospital in Washington, D.C. Dr. Kaplowitz was on the faculty of the VCU School of Medicine in Richmond, Virginia, and then moved to Washington to become chief of endocrinology at Children's Hospital. Since retiring from Children's Hospital, he's been volunteering at Neighborhood Health Virginia, a federally qualified community health center in Alexandria, Virginia, and we're just so very lucky to have him as a MAVEN project volunteer. So Dr. Kaplowitz, when you're ready, please begin.
Okay. Hi, everybody, and welcome. And I hope that you find this session helpful. And, my goal is to really help you to understand when you need our help. And, our help is readily available. So right now I'm trying to figure out how to advance my slides. And
You want to actually pull up your slide deck first, go back to Zoom and hit the share screen button, please.
oh, hold on. I'm not seeing the share. Okay, so this is my disclosure. And I think Kristen has already told you that this is available for CME credits. So I want to start by explaining, what my goals are. And I want to discuss several cases involving somewhat abnormal endocrine studies to illustrate how an endocrinologist would interpret and act on the results. But I also want to get into the more general issue of trying to define when a test is really abnormal and how it may relate or not relate to the problem which led to ordering the test in the first place. And my purpose is to encourage thinking about doing fewer tests, endocrine tests, in situations where a truly helpful abnormal test is unlikely. So I'm going to present a number of cases, and you'll have a chance to vote on your preferred option. And sometimes there's more than one option that is, acceptable. So the first case is a 13-year-old girl brought in for severe fatigue for the last 3 months, trouble sleeping, getting up in the morning, even after a good night's sleep. Her appetite is fine. Her medical history is negative. She's not on any medications, and her exam is normal. And you order a bunch of tests, and most of them are fine. Her free T4 is normal, but the TSH is somewhat elevated. So my first question is, what would you do next? Repeat the thyroid tests, consult right away with a pediatric endocrinologist, start thyroid hormone, and then try to get her seen by an endocrinologist as soon as possible, or tell the parents that none of the tests ordered suggest a particular reason for their daughter's fatigue. So I'll give you a minute to enter your preferred choice. So you decide when we should go on.
Well, yeah, we'll give it about 10 more seconds. I see some people still answering. We're almost there. Almost 100%. All right, we'll end it. And here are the results.
Okay, so it looks like we've got a variety of responses, including with the most popular one being to repeat the thyroid tests or consult an endocrinologist. Anyway, and not many, so let me explain. We're going to do another, oops, it's not advancing. Huh.
If you go down to the bottom left corner, you'll see like a little arrow. If you click on that, there you go.
Oh, there we go. Okay. let me just, okay. So we have another case. And this one is a 10-year-old obese boy who is pretty obese, and you do thyroid tests to exclude hypothyroidism. And this time, the free T4 is low, but the TSH is normal. So which of the following would you do? And I will then discuss both cases.
About 15 more seconds for any last minute. All right. Here are our results.
Okay. So the most popular option is repeat the tests, and if results are same, refer. Okay, well, let's talk about, first of all, a little thyroid physiology. The thyroid gland activity is regulated by both the hypothalamus and the pituitary. And the hypothalamus makes TRH, which stimulates the pituitary to make TSH, which then gets the thyroid gland to make both T4 and T3. And these hormones have effect on multiple target tissues, including the heart, liver, bone, and central nervous system. But most important for our discussion is that the T4 and T3 feedback negatively on the hypothalamus and the pituitary. So in theory, if the T4 and T3 are low, this will result in a loss of negative feedback and a rise in TSH to restore normal thyroid hormone levels. So in these two cases, here are things to think about. You have to ask yourself if the out of range results are meaningful in the context of the patient's symptoms. Patients with true primary hypothyroidism, even mild cases, will typically have a TSH of greater than 10. And if the TSH is greater than 20, then they should be seen promptly. And the symptoms are very variable and depend on the duration of the hypothyroidism, and really more how low the free T4 is than how high the TSH is. Now, secondary hypothyroidism will result in low free T4 with normal TSH, but this is really fairly rare without other pituitary problems or history of brain tumor or radiation. So my advice is don't worry about low free T4 with normal TSH, but if the free T4 is really significantly low, then you should consult with MAVEN or your local pediatric endocrinologist. And one of the things that people want to do is repeat the tests right away. And that's typically not very helpful because, if you do the test, 1 week and then repeat it next week, the likelihood is that the results are going to be about the same, and you're not going to, be any further along. So, you could either tell the parents, this isn't why your daughter is fatigued. This is not why your son is obese, but, we'll keep an eye on it. And, not, but, neither of these cases need to be seen by a pediatric endocrinologist. And the high TSH is really often transient, and, 3 to 6 months down the road, it may normalize without doing anything. But now you see a 15-year-old girl who complains of losing 10 pounds in the last 2 months without trying, but she's eating very well. She also feels warm when other people in the same room do not feel warm. Her medical history is unremarkable. What would you be looking for on her physical exam?
You can just type into the chat what you think you would look for in the physical exam. And I'll read the answers. Proptosis? Proptosis?
Anything else?
Enlarged thyroid,
Okay, that's a good one.
and then another proptosis.
Okay, well, these are the most common findings. Proptosis is seen, but, maybe a little less than half the time, but almost every case will have a large symmetric goiter. And, tachycardia is very common. This patient had a heart rate of 110 with a wide pulse pressure. You'll find brisk pulses and an increased precordial impulse, and then warm, moist skin, and many times these patients will have trouble sitting still. So the next question is, what tests would you order? And I will just tell you what I would order if you're, a primary care provider. So all you really need if you're suspecting an overactive thyroid is a total or free T4 and a TSH. And in true cases, they will not be borderline. The free T4, which normal range usually goes up to about 1.6, won't be 1.7. It will be usually greater than 3, and the TSH will be very low. There are other tests that you can do, including T3, various antibodies, and imaging, but that really can be left to the discretion of the endocrinologist. So your, point is you want to quickly be able to confirm your suspicion that this is an overactive thyroid, and then get your patient in quickly to see an endocrinologist if your suspicion is confirmed. So the question really is, when do you really need to do thyroid testing? And for one thing, I want you to keep it simple. For screening purposes, either a total or a free T4 and a TSH is sufficient. Any patient with a goiter, especially if it is of recent onset, if you're following up abnormal newborn screening results, if you have a patient who's been growing normally, but then their growth has really fallen off in the last year, if you have signs and symptoms of consistent with hypothyroidism, as we discussed, and if you have not fatigue all the time, but new onset fatigue, particularly if it's accompanied by cold intolerance. But when are thyroid tests low yield? They are low yield for obesity. If anything, you'll find this borderline TSH, which we don't do anything about, but is possibly related to the obesity. Most changes in behavior do not need thyroid testing, nor do you need it. So many patients have a positive family history of thyroid disease, and irregular periods are rarely related to thyroid issues. So the question really is, one of the questions is, should you be ordering endocrine labs as part of an obesity workup? There are endocrine conditions which can result in weight gain, such as hypothyroidism and Cushing's disease. But even in severe hypothyroidism, weight gain is modest, in the range of 5 to 15 pounds, and is due to fluid retention, not excess fat. But if the rapid weight gain is accompanied by slow linear growth, and that's assuming that the patient is not, late pubertal when growth normally slows, then the chances of an endocrine issue are much higher. So the big part of the problem is that we often see patients presenting with nonspecific complaints that do not point to a specific medical explanation. But in hopes of finding an explanation, a large number of tests may be ordered to make sure we're not missing anything. In addition, metabolic panels and CBCs are ordered for screening purposes when there's no complaint. But when one of these tests is mildly abnormal, should we assume that the abnormal test is clinically significant or the cause of the child's complaint? The problem is that the boundary between normal and abnormal is much fuzzier than many people are aware. Because when laboratories define normal, it's what they use as the 95% confidence interval. But what does that actually mean? And so here is, a particular test, and, you have within that 95% of patients fall within this bell-shaped curve, the fat part of the bell-shaped curve. But then there's another 5% that fall either on the outside, outer end or the inner end of that bell-shaped curve. But does that make any result really abnormal? How do we know if a person whose test is just outside the normal limits has a normal variant result or real disease? Some tests have a fairly tight normal range, so even a small deviation may be clinically relevant. For instance, if the serum sodium, which should be 135 to 145, but 149, which is not far outside the normal range, could be meaningful, especially if you're evaluating a child with excessive drinking and you're worried about diabetes insipidus. On the other hand, I was recently consulted by a MAVEN provider about a 2-year-old girl with new onset seizures, and she consulted me because the calcium came back 8.8 with that normal range of 9.2 to 10.8. But borderline tests like that do not result in dramatic symptoms like seizures. So let's do another case, moving to, glucose situations, which I know you are very commonly seeing. So you've got a 5-year-old overweight Hispanic boy who's sent to you for some screening labs. 3 days later, you receive a report that his CBC and urinalysis are fine, but on the metabolic profile, which was done at 10 a.m., his glucose comes back 118. And the parents tell you that he always drinks a lot. So which of the following options would you choose? So we're going to do another poll.
We'll have about 15 more seconds to close out the poll.
Okay, so actually, you all did great on this one because the answer that I would have chosen is to repeat the glucose, but make sure the child is fasting. I would not have ordered hemoglobin A1C. Yeah, so things to consider. While type 2 diabetes is becoming much more common in obese children greater than 10 years of age, it rarely presents as young as age 5. And a random glucose that's mildly elevated is likely normal if the child had consumed a lot of carbs 1 or 2 hours earlier. So the timing of the test, this one being 10 a.m. is important. So since the renal threshold for glucose is around 180, polyuria and polydipsia would not be expected. And these parents reported that your child drinks a lot, but this was not a new onset polydipsia. So I would conclude that this represents, unlikely to represent either type 1 or type 2, but fasting blood glucose is the best follow-up test. So when should you order a hemoglobin A1C in obese kids to rule out diabetes or prediabetes? This is a very challenging question, and there's no right answer. Yearly screening in severely overweight kids over age 10 to 12 has been recommended, but the studies show that it rarely identifies type 2 diabetes, which is hemoglobin A1C of 6.5 or higher. More commonly, the test will be in the borderline range, which is consistent with prediabetes. So prediabetes may progress to diabetes, to type 2 over time, especially if weight gain continues, but this could take years. So as a volunteer in a FQHC, I am referred many such kids, and we may treat the prediabetes with metformin, but I tend to wait until the hemoglobin A1C is over 6% to be sure that it's abnormal. And so will identifying a child with prediabetes motivate the child and the family to make needed lifestyle changes? Maybe. Sometimes yes, sometimes no, but you can certainly give it a try. So here's another glucose scenario. A 5-year-old boy had a screening urinalysis. Many people still do these. And there was glucose in the urine. And a random blood glucose on the BMP is 225. The parents are not giving you a history of polyuria or polydipsia. So how would you proceed?
Hold on 1 second. Let me launch. Sorry, I had a little issue getting to the poll. Poll is launched. Give it another 15 seconds or so. Those are the last minute participants. All right. This one's pretty evenly matched.
Okay. Well, yes, you've got everything, everything has been selected by people, although I only see 12 answers. I think we have more than 12 people. But anyway, let's see what we would suggest. So here are some things to consider. A random blood glucose of over 200 is diagnostic of diabetes, even in the absence of symptoms. And if it's 150 to 200, that's pretty suggestive. But that's unless the child is on medications like high-dose steroids, which can elevate blood glucose. And at age 5, this is much more likely to be early type 1 than type 2. So during the time that it takes to schedule and review results of an oral glucose tolerance test, your patient could become sick. Type 1 diabetes can go from asymptomatic to moderately symptomatic to pretty sick in a period of a week or two. So this is one case where having a pediatric endocrinologist involved early will make sure that definitive testing, such as a fasting glucose or a hemoglobin A1C, is done promptly and acted upon. Okay, moving on to another case. You are seeing a 7-year-old girl on a well child check, and you find that she has Tanner stage 2 pubic hair and underarm odor for the last 6 months. Her height is 90th percentile, weight is 95th percentile. There's no breast development. The genital exam is normal, except for pubic hair. The parents don't seem particularly worried. What would you do next?
Give it about 15 more seconds.
Okay, so looks like a lot of people would order labs, and a couple of people would refer, and a couple of people would reassure. So let's see what I would suggest. So let's say you decided on option 2, which is, you do the lab tests and you get the following results. So then your next move would be, do you tell the parents that the tests are about what you expected, but you want to see a specialist to be sure? You want to order a CT scan of the adrenal glands, or ask your local pediatrician, endocrinologist, to see her as soon as possible to rule out an adrenal tumor. I'm not sure we did a poll for this one, did we?
Which one? We have it. Yeah. Back. Okay. Poll is launched. Fifteen more seconds. All right.
Okay, so we have split between most either saying that's about what you expected, or only one person wanted a CT scan, but a lot of people thought that this was a situation where you'd want to get the patient seen as quickly as possible. So let's talk about what we are seeing. Many of you who have been in practice for a while have seen cases like this. And this is what we call premature adrenarche, which is a benign normal variant of puberty due to an early increase in adrenal androgen secretion before the gonads are really kicking in. So typically, the only abnormal test finding is an increase in DHEAS, which is the major circulating androgen. And our patient had an 80, but it can be high as 150 or 200. And I was glad to see that people weren't ordering FSH, LH, and estradiol, because those are really only helpful if breast tissue is present. Virilizing adrenal tumors and congenital adrenal hyperplasia causing early pubic hair is extremely rare. And, the red flag is that these girls have an enlarged clitoris. So I think, going back to the original question, if you've seen a number of these cases and you know that this is a benign normal variation, reassuring the family is fine, and you can arrange follow-up in 6 months just to make sure that it's not progressing. But, many people aren't comfortable, with reassuring if they haven't seen a lot of these cases. So referring to pediatric endocrinology is fine. But if you do that, I would advise you not to order any tests, because in my field, providers are all over the place, but I would say more than half will just diagnose this on clinical grounds and not order any tests. Some will do the tests, but leave that up to the endocrinologist rather than ordering the tests in advance. Okay, so you are seeing an overweight 10-year-old and decide to screen him for vitamin D deficiency because you've read that overweight kids are more likely to have vitamin D deficiency. And you order the correct test, which is a 25-hydroxy vitamin D, and it comes back as 20.5. And the normal lab range is given as 30 to 50. You had ordered a metabolic panel, and the calcium and alkaline phosphatase are normal. So in this case, would you prescribe 50,000 units of vitamin D for 8 weeks, assess his vitamin D intake, and if low, suggests a supplement, or consider that his vitamin D is fine and do nothing.
We'll wait about 15 more seconds to finish the poll. And we have a comment in the chat, it just depends when checked.
When, as in time of year?
Maybe. Was it in the fall, so likely to drop?
Yeah. Okay.
Share results.
All right. So a couple people would treat with high-dose vitamin D. A lot of people would assess to see if his intake is low and suggest a supplement. And a couple people would say, yeah, it's fine. So here's an interesting thing is that recommendations about vitamin D have been changing, because the Endocrine Society a number of years ago recommended that vitamin D levels should be greater than 30. But nowadays, most experts feel that any level 20 or above is adequate. And many studies show that evidence of vitamin D deficiency is rare unless levels are less than 12. And even then, patients are often asymptomatic. But, this is probably not going to go over well with many providers, but we've come to think that vitamin D should mainly be done when there is hypocalcemia, meaning a serum, you get it because you've got a serum calcium of less than 8. And that is especially likely in breastfed dark-skinned infants, where we're still seeing low vitamin D because of failure to supplement, or evidence of rickets on an exam or an X-ray. For other children, including obese children, it's really better to assess milk intake and sun exposure and advise a daily supplement if vitamin D intake appears to be low. And that supplement should be at least 400 units, but it could be as much as 1,000 units. But, if you start getting vitamin D levels and they're a little low, and then you supplement and you repeat, that adds a lot of cost, but little benefit. And, a vitamin D supplement, if you have a kid who's not drinking any milk, particularly if they're dark-skinned, is really much more cost-effective than, getting vitamin D levels. So let's talk about test ordering and the cost of healthcare in general. Ordering more tests than is necessary really contributes to the rapid rise in healthcare costs. It's not the only factor, but it's one of many. And it's not really making our children any healthier. That is particularly true when you order tests for completeness, when the history and physical do not point to any specific diagnosis, or the patient doesn't have risks of, like things like anemia. And, the more tests you order, the more likely you are to find a result that's flagged as abnormal, meaning that it's outside the 95% confidence limits. One example of over-ordering tests is a mildly short child who is growing normally close to the 5th percentile. And I know you've all seen these patients in your practice. But what people often don't know is the low value of workup for healthy short kids. And there was one study published in 2013 from Cincinnati where they looked at the diagnostic value of typically ordered screening tests in over 300 short children who had a normal exam and a normal rate of growth. Only one patient who was really quite short and well below the curve was found to have a lab test that was clearly related to his short stature, which is a very high tissue transglutaminase IgA, which led to a diagnosis of celiac disease. But, one of the things that people are not aware of is how much these tests cost. And I've listed here the cost of these tests at Children's Hospital. Now, I realize that commercial labs may charge less and insurance is not going to pay. But, if you work at a safety net clinic and you order these tests and the patient doesn't have insurance, it's going to come out of a budget that may be limited. So, just so you are aware of what these tests might cost. I was kind of shocked that a comprehensive metabolic panel costs $600. I'm sure it's much cheaper at LabCorp, but if you think of all these tests that are typically ordered for short stature, they can really add up and can end up, being close to $2,000. So here are some final thoughts. One reason that there are so many abnormal test results is that many tests are ordered for patients with weight issues, mild short stature with normal growth rates, fatigue. And keep in mind that 5% of healthy kids will have values outside of any lab test normal range. So if one orders 20 or more tests, there's a good chance that at least one result will be abnormal. And, my, suggestion is to hold off on non-selective test ordering while monitoring the patient for whatever symptom they present with. But I also realize that this may be challenging, particularly because parents, are fixated on, there's a medical explanation for why my kid is so tired, or, medical explanation for why my kid is gaining weight rapidly, which we all know is happening at an alarming rate. So I realize that this may be challenging when parents demand that you do something. So the most common type of question I get as a MAVEN volunteer is, I saw with patients with X and ordered, and then they give me a long list of tests, which are all normal. What other tests should I order? And, one of my suggestions is that before you order such a long list of tests, you might say, here's a scenario that I'm dealing with. And, what tests do you think would be most helpful? And we are more than happy to advise you. And we may say, don't do any tests. So when confronted with an abnormal test, consider whether the test is likely to be abnormal in a clinically significant way before referring to a specialist. Test results which are slightly outside the reference range rarely, if ever, cause problems. And, how important is it to distinguish subclinical disease states from normal variations? On the other hand, you're going to get test results that are well outside the normal range, such as a very high or very low TSH. And those are, or the glucose, random glucose of 200, and that's a different story. So I would like now to open it up for questions. I hope that I've given you something to think about. I know that, some people are comfortable with the way they practice and maybe don't want to change it, or, just have some questions that they would like clarified.
Yeah, thank you. This was fantastic, Dr. Kaplowitz. Just a reminder, if you have any questions, put them in the Q&A box, use the raise hand feature, speak directly to our speaker. I guarantee you I will mess up big words, so it's always helpful. We have our first question. Should we be doing thyroid testing for overweight or obese children? What about fatigue, and what about constipation?
Okay. Yeah, I thought I had covered the obese issue, but, there are a lot of studies on thyroid tests and obesity. And, underactive thyroid is not a cause of obesity. And so, you're likely to be, but on the other hand, it's been shown that obese patients have slightly higher TSH levels than normal patients, meaning that the possibility of having a TSH in that borderline range of 5 to 10 is higher if you are obese than if you're of normal weight. So if you order thyroid tests for obesity, yeah, you're going to get, these mildly abnormal tests, but you're not going to get a test that shows severe hypothyroidism, because that might cause, 10 pounds of weight gain. It's not going to cause 30, 40, 50 pounds of weight gains. In regards to fatigue and constipation, yes, they are symptoms of hypothyroidism, but they're generally combined with other symptoms. So if it's just fatigue or just constipation, the chances that you're going to find an explanation, a thyroid related explanation, are pretty low. But, if it's more than one symptom, like fatigue and cold and, recent onset cold intolerance, particularly if it's recent onset fatigue, or constipation and, lack of energy or sleeping too much, if it's more than one suggestive symptom, yeah, it's probably worth doing a T4 and TSH. But for isolated symptoms or obesity, the yield is going to be very low.
Okay. I've been getting a lot of patients requesting random cortisol levels because social media tells them it causes stress and anxiety. How would you respond to this?
Yeah, I don't get that. We don't get that issue coming up as much, but I can tell you that, there is this feeling that, adrenal fatigue is a common. I think it's more often a concern that adults have than kids have. But the problem with random cortisol levels, first of all, is that cortisol is very time of day dependent. You're going to get much higher levels, at 8 or 9 in the morning than you're going to get at 3 in the afternoon. So it's always, a little hard to interpret, a cortisol, an isolated cortisol level. But the time that cortisol levels are most useful is, first of all, if you've got a patient with, Cushingoid features, rapid weight gain, which is more around the trunk than the extremities, and the classic moon face, definitely a cortisol level then. But, the adrenal insufficiency that is clinically significant, that we also call Addison's disease, is extremely rare. And, so in that case, you're not only going to have fatigue, but you're going to have weight loss, and you may have salt craving. So, I can think of only a handful of cases in my career of, Addison's disease that I've seen. But, you've really got, before you start worrying about adrenal insufficiency, you should have more than one symptom, not just fatigue, but fatigue and weight loss, or fatigue and salt craving, things like that.
Great, thank you. As environmental pollution increases, the amount of endocrine disruption, and you said many have a family history of thyroid disease, could the normal range change due to more abnormalities in the population? Thus, normal may include what was abnormal prior.
That's a tough question to answer, because there really haven't, yes, I mean, we know that there are environmental chemicals that can affect endocrine function. But the link, and there are many, many studies that have tried to link, endocrine disrupting chemicals with either earlier puberty or later puberty. And those studies are right now inconclusive, but I'm really not aware of any studies that have linked environmental chemicals to either, overt thyroid disease, or, because it would be really hard to do a study, showing that the normal range for a thyroid test was affected by, you'd have to have a exposed group and a control group, and that's, very hard to get, since the truth is that the vast majority of us have some exposure to endocrine disrupting chemicals. So I would answer that we don't have any evidence right now that the normal range of, our common tests is affected by endocrine disrupting chemicals.
Thanks. I don't see any other questions right now, but we will pause and wait. Just to remind you that your CME survey will pop up in a tab on your browser. Click that link, complete your survey. You have the correct date, February 4th, correct speaker, Dr. Kaplowitz. You will get your CME certificate almost immediately. something's wrong, I'll fix it.
Yeah. Can I just ask for people to say whether anything that I have presented today is likely to lead to a change in the way you approach certain problems and the type of tests that you would or would not order. Any thoughts about whether I have had any effect on how you view these situations?
While we wait for responses, please put them in the chat or the Q&A. We do have a question, so we'll wait for but we'll stall by asking, does cortisol need to be checked before thyroid hormone is started?
I don't routinely do it, but I think it depends on, I think that for, the common thyroid conditions, what we call primary hypothyroidism, which is the thyroid is failing, and you have a low, free T4 and a high TSH. No, there's no reason to check a cortisol level. On the other hand, if you have a pituitary thyroid issue such that your a free T4 is significantly low and your TSH is not elevated, then then you're suspecting that this might be a central hypothyroidism. And the truth is that those, if you really are worried about central hypothyroidism, that the free T4 is not just borderline low, but significantly low, that is something you should discuss with your local pediatric endocrinologist and not something you should be wrestling with yourself, because that could be a more serious problem.
Well, I don't see any responses to your question, but I will share the survey results and feedback with you.
Okay.
All right.
All right. Well, I enjoyed.
Oh, I'm sorry, I lied. I feel more confident in premature without a big workup, so thank you.
Yeah, I mean, premature adrenarche is so common, and and I have studied, I have published papers on premature adrenarche and have come to the conclusion that, after you've seen a number of cases, and of course, in my long career, I've seen, well over 1,000, you can recognize, the typical presentation, the kid with a little pubic hair, no other signs of puberty. The growth, is usually going to be at the upper end of the curve, but body odor is extremely common. And when you see that constellation, I think at some point get to the point where I know this, I don't need a pediatric endocrinologist to tell me what I can diagnose clinically. And then you feel, yeah, I can help these patients without generating extra medical costs. Anyway, great talking to you all.
Thank you so much. If you have any other questions, remember that you can always reach out to Dr. Kaplowitz or any of our MAVEN Project volunteers on our e-consult platform. So have a great day, everyone.
Bye-bye.